Hi, good morning, students. So, today again we are with another new topic called plantar fasciitis, which is a very common and popular problem seen among the population. And first, let us start with the description. So, plantar fasciitis may be referred to as plantar fasciosis or plantar heel pain, plantar fascial fibromatosis, and among others. Because many cases diagnosed as plantar fasciitis are not inflammatory conditions. That is why it may be referred to as plantar fasciosis. And this is confirmed through histological analysis, which demonstrates the plantar fascia fibrosis, collagen cell death, vascular hyperplasia, random and disorganized collagen, and avascular zones. So it is also called as plantar fasciosis, and we can use the term plantar heel pain, which serves to include a broader perspective discussing this pathology. Now let us come to the relevant anatomy. The plantar fascia is comprised of white longitudinally organized fibrous connective tissue which originates on the periosteum of the medial calcaneal tubercle, and it extends to a thicker central portion. The thicker central portion of the plantar fascia then further extends into 5 bands surrounding the flexor tendons as it passes all the 5 metatarsal heads. It originates from the periosteum of the medial calcaneal tubercle and then extends into the 5 bands surrounding the flexor tendons as it passes all 5 metatarsal heads. The plantar fascia is best referred to as fascia because of its relatively variable fiber orientation as opposed to more linear fiber orientation of aponeurosis. The plantar fascia blends with the Achilles tendon, the intrinsic foot musculature, and even the skin and subcutaneous tissue. And this viscoelastic multitubular fat pad is responsible for absorbing up to 110% of the body weight during walking and 250% during running, and deforms most during barefoot walking. So during weight bearing, the tibia loads the foot and creates tension through the plantar fascia, which is known as windlass mechanism. The tension created in the plantar fascia adds critical stability to a loaded foot with minimal muscle activity. And this stabilizing nature of plantar fascia is evident when following cases of post-surgical release, which may lead to midfoot arthritis, rupture of the secondary stabilizers of the arch, spring ligament, as well as other pathologies. So let us have a quick look on how the plantar fascia looks inside our body. So as you can see here, the white structure that originates from the calcaneal tubercle, and then it spreads into a thick structure here in the middle, and then it spans into the 5 bands surrounding the 5 metatarsal tendons, and then it blends with the musculature, intrinsic foot muscle, also with the skin. So this is the plantar fascia which is present in our sole. Let us move to the etiology part. If you see the etiology, the average plantar heel pain episode, it lasts longer than 6 months and it affects up to 10 to 15% of the population. However, 90% of the cases are successfully treated with conservative care, and this condition is seen in all the ages and commonly experienced during the middle age. Females present with plantar heel slightly more than male and occurs more frequently in the athletic population, such as running, which accounts for up to 8 to 10% of all running related injuries. There are certain risk factors which contribute to the plantar heel pain, and those risk factors, some of the risk factors are loss of ankle dorsiflexion, that is in the talocrural joint, and then pes cavus or pes planus deformities, excessive foot pronation dynamically, impact or weight bearing activities such as prolonged standing, running, improper shoe fit, elevated BMI that is more than the required per kg per meter square, and then also seen in metabolic conditions like diabetes mellitus. So these are some of the risk factors. Then let us come to the clinical presentation. Clinical presentation. The heel pain with first steps in the morning or after long periods of non-weight bearing. So the morning heel pain is a classical symptom of this condition. Then there will be tenderness to the anterior medial heel. There will be limited dorsiflexion and tight tendoachilles. The Achilles tendon will be tight, limited dorsiflexion. There may be a limping present, and there will be a preference to toe walking because the person cannot place the foot fully down. Pain is usually worse when barefoot or on hard surfaces, also with stair climbing, and many patients have a sudden increase in their activity level prior to the onset of symptoms. Next, let us come to the differential diagnosis. So we can divide the differential diagnosis into certain factors like neurological, soft tissue, skeletal, and miscellaneous. So if you go for neurological, there may be abductor digiti nerve entrapment, there may be lumbar spine disorders, there may be problems with the medial calcaneal branch of the posterior tibial nerve, and also tarsal tunnel syndrome. If you go for the soft tissue factors, there may be Achilles tendinopathy, fat pad atrophy, there may be heel contusion, plantar fascia rupture, posterior tibial tendinitis, or retrocalcaneal bursitis, which are some of the soft tissue conditions. If we go for the skeletal, there may be calcaneal stress fracture, infections, inflammatory arthropathies, subtalar arthritis, and last but not the least, the miscellaneous like the metabolic disorders, osteomalacia, Paget's disease, sickle cell disease, tumors, vascular insufficiency, rheumatoid arthritis are of the few conditions to name off. Next, let us look for the diagnostic procedure. It is a clinical diagnosis. It is based on patient history and the physical examination. Patients have local point tenderness along the medial tuberosity, and the plantar fascia pain is especially evident upon dorsiflexion, and therefore any activity that would increase the stretch of the plantar fascia, such as walking barefoot or without any arch support, climbing stairs, toe walking, can worsen the pain. The clinical examination will take under consideration of a patient's medical history, physical activity, foot pain and symptoms, and the footwear, his daily activities. So the doctor may also decide to use imaging studies like ultrasound or in case needed MRI. Then in outcome measures, we can use the foot and ankle ability. Foot and ankle ability measure. Foot and ankle ability measure. This is a good outcome to give patients that are diagnosed with plantar fasciitis. Also, a few studies have been done on foot function index, and but the foot ankle ability measure is a good outcome measurement. Now, the important thing is on examination. So on examination, we'll find a reduced ankle dorsiflexion. Maybe the patient is obesity, or work related weight bearing. There is a special test called the windlass test. The windlass test. Windlass test. It is a special orthopedic test to provoke symptoms that the plantar fascia by creating maximal stretch. So in the windlass test, the patient is supine lying and the foot to be examined will be out of the couch, and the examiner grabs the foot, stabilizes the ankle, dorsiflexes passively and creates a maximal stretch where the pain will be a positive sign of this test, and this is popularly used, called the windlass test. Also, imaging studies like ultrasound, MRI are used sometimes to confirm or go into details, because the advantage of ultrasound is that it is non-invasive, greater patient acceptance, and radiation free, also cost effective. If we come to the medical management, First, when the conservative management fails, surgical plantar fasciotomy with or without heel spur removal may be employed. This is an open procedure percutaneously or most commonly done endoscopically that releases the plantar fascia. This is an effective treatment without the need for removal of a calcanean spur when present. And 70 to 90% of heel pain patients can be managed by non-operative procedures, as I said earlier, and surgery should be considered only after the normal conservative treatments have failed or the patient is not improving. And the endoscopic plantar fasciotomy using the visual analog scale, the average post-operative pain was improved from 9.1 to 1.6. So the endoscopic plantar fasciotomy is one of the surgical procedures commonly used. It gives better results and quicker healing. Coming to the physiotherapy management, it includes stretching of the gastrocnemius and soleus muscle, the plantar fascia. We can use the ultrasonic therapy, iontophoresis, sometimes night splints, joint mobilization and manipulation. So the PT management includes the stretching of the calf muscles, that is the gastrocnemius and soleus, the plantar fascia, ultrasonic therapy, iontophoresis, night splints, manipulations, also needling and taping has proved to be a very effective physiotherapy management for this condition. So also strength training, similar to tendinopathy management, high load strength training appears to be effective in the treatment of plantar fasciitis. Then stretching, stretching consists of the patient crossing the affected leg over the contralateral leg and using the fingers across to the base of the toes to apply pressure into toe extension until a stretch can be felt along the plantar fascia. Then Achilles tendon stretching can be performed in standing position with the affected leg placed behind the contralateral leg with the toes pointed forward. And mobilization and manipulations to decrease pain and relieve symptoms are seen. And posterior talocrural joint mobilization and subtalar joint distraction manipulations have been result oriented and it improves the pain. Then sometimes we go for posterior night splints to maintain the ankle dorsiflexion and toe extension, allowing a constant stretch on the plantar fascia, and some evidences reports night splints to be beneficial, but there are limited evidence to support the use of night splints to treat patients with pain lasting longer than 6 months. Then you have the iontophoresis, foot orthosis, also taping, which is a very good method for plantar fasciitis. For an entire week, the tape was placed on the gastrocnemius and the plantar fascia. It was concluded that the additional treatment with continuous taping for 1 week might decrease the pain better than other therapies. And since this is a clinical picture of the plantar fasciitis, we will go into the details of the taping and the needling and the taping techniques in the next lecture. Maybe I will share with you guys some of the stretching exercises of the heel. And so in brief, if we summarize the topic, plantar fasciitis is referred to as plantar fasciosis, plantar heel pain, and most commonly the term plantar heel pain is used because it has a broader aspect, and the structure which is mainly responsible is the plantar fascia, or the structure which originates from the medial calcaneal tubercle, and it extends into a thicker portion and then into 5 bands surrounding the flexor tendons as it passes all over the 5 metatarsal heads. And the clinical picture is that there will be pain in the early part of the day, that is after you wake up in the early morning, because this pain arises after a gap of activities, and females are slightly more common than males and mostly popular in the athletic population, accounting for 8 to 10%. And again, if we revise the risk factors, I told you there will be loss of ankle dorsiflexion, pes cavus, pes planus deformities, excessive foot pronation, impact of weight bearing activities, improper shoe fit, elevated BMI, diabetes mellitus, all these conditions. So yes, this is all about the plantar fasciitis. Please go through this video and also go through your book chapter. Any doubts, any queries, please feel free to ask or discuss in our Google Classroom or in our WhatsApp group. So okay, thank you guys.